Bore da, everyone. Welcome to this public session of the Digital Health and Care Wales Programmes Delivery Committee. I'd like to note that Simon Jones, who chaired the first session of this committee back in November, has asked me to take over as chair, which I was happy to do. I'd like to thank Simon for setting up the first of these sessions and for giving me the opportunity to chair this going forward. I'd also want to note that the members of this committee will sometimes not be looking directly at camera. We have a full set of papers related to this committee meeting, and occasionally we'll be looking away from the camera towards the papers for notes and comments or questions that we might want to raise. I'm planning to take a 15-minute break, probably after section 3, but we'll then resume shortly afterwards. In the interest of time, I'll ask people to introduce themselves when they first present or ask a question or make an observation. I'd also like to note for this public meeting that prior to this, we had a private session earlier today to deal with items which are of a sensitive commercial nature. For the record, I'd like to record that no decisions were made in that session and that we received updates on the iCare digitisation programme, Digital Maternity Cymru, Welsh Intensive Care Information System. We looked at a couple of private risks, and we also looked at the draft business case for the NHS Wales app DSPP programme, which is being developed at the moment. And again, no decisions were made. We just received updates on those things. I'll now move us on to the agenda item covering apologies for absence, and we have two that I'd like to note. Rydian Hurl, our Executive Medical Director, is not available, and Rowan Gardner, one of our independent members, is also unavailable. Declarations of interest, I've received none in advance of the meeting, so I'll just pause and see if there's anybody that wants to raise anything specific related to today's agenda. Okay, I can see no hands or anything, so I'll assume we don't have any. Matters arising from the previous meeting. We have within the pack that we've had received the minutes of the previous meetings. I've not received anything from anybody by way of comment or corrections on the minutes. We are asked to approve the minutes, so could I just check with everybody that there is no outstanding amendments that need to be made before we can approve it? Okay, so I've seen no indication of anybody wanting to raise anything, so we'll take the minutes of the previous meeting on the 9th of November as approved. We'll now move on to the forward work plan, and for this I'll hand over to our board secretary Chris Darling to talk us through that.
Thank you, Chair. Yeah, Chris Darling, Board Secretary for DHCW. We spent a fair bit of the last committee running through forward work plans, so I'm not going to go through item by item, but actually it's a fairly simple approach we've got. We've got the programme's overview dashboard highlight report as a standing item, and then we've got a number of annual assurance reviews that have been run through with Ivan as exec lead and agreed to go into that sequence for every public meeting. The only two I'll draw attention to, Chair, is we've also included benefits. We've had discussion about that. We've included benefits realisation, and there's a lessons learned review planned for LIMS and RISP in the future. And I guess lessons learned generally will be something we'll be looking to bring back as they relate to major programmes. And it's just for noting the annual cycles there for approval, Chair. Yeah,
okay. So could I just check if anybody's got anything related to the annual cycle of business they want to raise? Otherwise, we're seeking approval. Okay, I can take it that those are approved, Chris, for the minutes, and move us on to item 3.1, which is the action log. There was just one action from the previous committee meeting on the 9th of November, which was a development session. Evan is going to bring us on to that in a second. So there's no other actions outstanding. It was just that one. And that's a nice segue into item 3.2, which is over to you, Eamon, to give a bit of an update on that session. And perhaps you could pick up the benefits thing that Chris mentioned when he spoke a minute ago.
I can, certainly. Thank you very much, Chair. And members might want to come in several. It was the first. This is the first delivery. Development session that we've run for a subcommittee, and I think it was really valuable to us as executive and as staff within the organisation, and from feedback useful to independent members too, because we are setting things up quite quickly. So the first thing that we covered was the way that we've established the DHCW governance around the programmes and the portfolio, and where government had got to. So we just reviewed where that was, and as an update, I think I'll give that now rather than later on. At the end of November, Welsh Government has written to all of the appointed SROs for each of the Digital Investment Fund supported programmes, confirming a transition to portfolio oversight chairs, or programme oversight chairs. So those arrangements have now changed, and for all of our programmes, we're in those new arrangements. There's one exception, which is the digital medicines portfolio, which is the only portfolio that we have, and the portfolio will remain under the current governance arrangements until the end of March. Very strongly led by Hamish Lang as SRO, and then from the beginning of April we'll transition into the same programme pattern as the other programmes that we have. And the portfolio consists of a number of programmes, each of whom have got an SRO lead. So by April, we will have transitioned entirely to the new arrangements that have been put in place by government. And to support that, we've established a portfolio management office inside DHCW, which has been spinning up over the last few months. And we've also been supporting that with a revised arrangement for our management board, which is a dedicated portfolio oversight session for management board. That first met around about the same time as this committee first met in November of last year. So it's kind of got into a pattern of working now. It meets every month, and that is going well. And I think you can see some of the outcome of that comes through in the reporting that we've got. And a lot of the emphasis initially has been on standardising and making more regular and more familiar the way that we report, and making that consistent across the different programmes that we have, using the same RAG framework for different programmes, for example, so that everything is coming to a similar pattern. And that was the first formal discussion item that we had at the development committee. So we covered three things. One was the scope of the portfolio, which was something that was raised at the first programmes delivery committee. Then we looked at the life cycle of programmes. What's the pipeline before and the lessons learned afterwards. And then we looked at how do we get a view of benefits, how do we track benefits most effectively. On the scope of the portfolio, there are a set of, we've designated a limited number of major programmes, which is the programmes that you see on the agenda today in the highlight reports pack. Those will come to and what we agreed as a committee in that development session was that those will come every single time to this meeting for review, for, if you like, regular assurance because of their status as major programmes. In our management board, we also review a number of other smaller programmes, and those will be escalated to this committee if there are any concerns or if there's a view that there's additional assurance which is required. So they can be within the purview of the committee, but the committee's got limited time, and therefore we're going to focus on a few things as a regular call. And then those other programmes are also covered, but would only be escalated if they need to be escalated through the mechanisms that we have. So that's how we manage the scope. And it's also in the terms of reference that we review the scope of the committee at least annually. And this is the second meeting. So we will continue to do that on a regular basis, working closely with committee members. The second thing that we covered was life cycles. It was a part of the reason for these changes is to try to think about how the whole portfolio fits together. And the whole portfolio is not just the breadth of the portfolio in terms of the interdependencies between one programme and another, and how they might share resources and capacity, the sorts of things that the portfolio management office is seeking to support while programmes are in flight. But also, what's the before and after? How do we get a better view of the pipeline of future programmes? How do we marshal that intelligently so that we have programmes coming through, that we understand how they're developing in terms of their maturity, when they're going to hit delivery? And then also what happens, after a program is closed by delivering its outcome, we still need to learn lessons. We still need to review and track the benefits that we've had. Last week, I think it feels maybe as if it was longer away, but I think it was no, it was 2 weeks ago. It was a week and a half ago at the SHA board. Committee members signed off on the draft DHEW strategy, which we're going out to engage with through February, and that includes as one of its strategic objectives for 2030 a forward pipeline of programs, which is supported by all of our key stakeholders and delivery partners. So these two things mesh together. We need to have a full picture of what's coming down the track, and so that this committee is cited on that, and so that we can manage that as a whole portfolio. And then the final part of what we discussed was benefits. It was packed 2 hours. It was really good. The final part of what we discussed was benefits, and this is a combination of how to have a consistent framework for benefits across all of the different programs, so that we're not reinventing the wheel each time in each program, and that we can first make the job easy for ourselves, and secondly aggregate those benefits up in order to give a compelling case about the value of digital in the round overall. You know, how do all of these digital transformation programs reinforce each other? One of the things that we discussed was that very often a digital transformation program, you know, most programs are there to deliver an outcome, and it's the outcome which delivers the benefits. So that has two impacts. One is that the benefits don't really start to flow until after the program has done its work, which is to deliver the outcome. And secondly, the benefits flow to the delivery partners who use that digital product, not to us, DHEW, directly as an organisation. And we had a very candid discussion, and there are also some challenges there about who then collects and tracks and reports on those benefits, because the program governance and the program machinery has stood down and it's become part of daily use and ordinary practice. So how do you protect the resources that you need to go out and scrape the benefits and to report upon them? So we covered quite a few things there. Claire, as the finance director, is leading on the benefits framework. That is the pattern and the guidebooks and the templates that we want to put together, a standard way of measuring some key things. And it'll be the Portfolio Management Office, this committee, Portfolio Oversight and Management Board, that will try to look at how good are we at forecasting benefits? How good are we at embedding the routine automated collection of and reporting of benefits in whatever digital solutions that we provide? Do programs baseline, because it's important that they baseline within the life cycle early. And what do we learn after a program has closed from reviewing the benefits it's delivered? Were they the ones that we anticipated? Were they of the scale? And are we doing a good job of capturing those benefits in the most effective and efficient way? So we got through a lot. I felt, and it was a really productive meeting, and you can see a lot of that playing through, including a session on benefits on the forward roadmap. So I'll stop there, and just if anybody wants to add comments or questions, then of course handle that.
Okay, thanks, Stephen, for that comprehensive update. Anybody want to add anything to what Evan said or ask a question? Okay, I can't see anybody, so I will add one point, Evan, which is there was a little bit which came out of the session that we had on benefits subsequent to the meeting you've been talking about, which was basically this programme will basically just establish at the end of the major programme that there is some agreed metrics in place to measure the benefits, and that we have the appropriate buy-in from the stakeholders for where the benefits sit, which is by and large in the wider NHS. That's the point at which it then transitions over to the DG, Digital Governance and Safety Committee, who will keep a watching brief on those benefits over the life cycle. So we have some feedback to feed into how we manage these things going forward. So that's the only thing I wanted to add to what you said, which is quite comprehensive. I'll just pause for a second if anybody's got anything on the raise. Otherwise, Evan, I'll ask you to move on then to the programmes overview report.
Great, thank you very much. So, so first, I want to thank teams in the Portfolio Management Office, in the programmes themselves, for the work that they are doing, which you can see reported in summary in the assurance highlight reports. There's really good progress across several programmes. Some of that is delivery progress in terms of going through key milestones for the NHS Wales app, for example, and digital medicines transformation programme, really important milestones that are being hit to time and to target. And some of that is kind of under the hood, to do with the governance of programs, or is to do with the contractual position, or is to do with the really important stakeholder relationships that we have, and our relationships with health boards as delivery partners, etc., which is less evident externally, but is as important, if not more important. So teams have been working really, really hard, and I'm really pleased with the way that they're doing that. I'm also pleased with the pace at which we are managing to converge, I suppose, let's say, right, to converge on standard reports, standard RAG frameworks, and others. We know, and a part of the reason for setting up this committee and setting up the Portfolio Management Office is that programs are very different in the way that they've been constituted. They have different terms of reference. They have different styles of working, and you know, they're sometimes necessarily different because they have quite a different job to do. But there's more variation there maybe than we felt was strictly needed. It's quite complex, and we are trying to simplify everything that we do, and we're trying to bring that together into a more consistent pattern. And on top of that, we're also trying to drive efficiency. So as an example of that, I was really pleased that these assurance highlight reports were used as the core of our quarterly IQPD reports on accountability to Welsh Government. Rather than asking teams to write a whole new set of reports containing the same information in a different format, we were able to use these same reports for a different purpose because they covered what was necessary. And yesterday, because it's Tuesday today, there was a meeting with Welsh Government to talk about how we could do that for some of our routine Digital Priorities Investment Fund returns and reporting as well, which is, you know, it's intensive reporting. Can we use management highlight reports? Can we use the standard documentation that we use in programs? And I think that is really important. First, because what I want is standardization and consistency and a common shared understanding. But what teams want is less onerous work mapping things from one template to the other. And it's really important that we can get that balance, that there's something which is valuable to our teams, especially when we're under pressure in terms of resources and other things. So it's good to see this coming together, and it's good to see it mature. So I'm just going to go through the cover sheet, and then we'll take questions as we go through the individual assurance highlight reports. The National Data Resource is the first thing which is in the report, which is highlighted, is in the cover of the slides, and is also in the cover page in the document. So it's still maintaining a green status in terms of its overall, and I should say that the RAG status here is determined by the program board in each case. So I as the lead executive director, I don't overrule the RAG status that a program board determines for itself. In all of them, the program board will call its own RAG status. What we're doing is trying to provide, we are providing a consistent RAG framework so that they're all trying to do that in the same way. But I think it's really important that program boards own their delivery confidence. They are the primary governance arrangement for the safe delivery of that program. So there are some recruitment challenges. There's a lot of posts to recruit in the year end. We've boosted the resource that we've got behind that by bringing in some additional temporary staff to make sure that we hit the targets that we have to the year end on that. We've got 3 programs which are in an amber green state, so we use a 4 RAG rating. So we've got 3 programs in amber green. One is the digital services for patients and the public. We're on track with GP practice adoption, so all of the EMIS practices are connected. Cegedim practices are lined up between now and the end of March. Really, really close, productive, effective working between the primary care team and the NHS Wales app team, particularly. It's an intensive time of year over Christmas, but it's and winter, but it's always an intense time of year. So it's really important that we maintain the relationships and we work closely between our own teams and with our external stakeholder partners. But that is on track at the minute, and we've got some additional things that we're working through in a work package 10, as we call it, for the NHS Wales app, around proxy access and a few other things. And we anticipate going to a public communications and promotional campaign sometime early in the next financial year, when we know that we've addressed the remaining concerns that we have. And that's exactly what the public beta program was intended to expose. So that's on track in terms of those things. We've got an update on the Bridgend transition program and the WPAS as a sort of a review coming up later on the agenda. So I won't go through into that in too much detail. Sam Lloyd will be joining us soon to give an update on that. And in the digital medicines transformation portfolio, This is amber green. It is going at quite a pace. So the Digital Medicine Transformation Programme is delivering very, very rapidly. The service proof of concept, the SPOC, which was a new acronym on me when I first discovered it last autumn, for the digital transmission of prescriptions in primary care from a GP to a pharmacy. That's past 2,000 digitally transferred prescriptions. It's just one GP practice in Brill at the moment, but that's making good progress, and that will be scaling up over the next few months as we bring other pharmacy suppliers onto that same pattern and that same digital way of working. We've then got 4 programs that are in the amber red position. Digital Maternity Cymru, where we've taken a pause on the outline business case in order to confirm Health Board sign up and to work closely with Welsh Government on their ambitions for an all Wales approach on this, working closely with the Chief Nursing Officer. So that's in its final draft at the minute. It shares with the Programme Board and with Welsh Government for comment prior to its formal submission. So that should happen within the coming weeks. On radiology and on the Laboratory Information System, committee members will be familiar with the RISC programme and the LIMS 2 programme. An enormous amount of re-engineering of those programmes, contractually, timelines, relationships, programme governance, programme management and delivery arrangements over the last 12 months. The revised timelines are showing good progress, and we're holding to our new timelines. It's a real credit, I think, to the teams that are involved in those. And then the Welsh Community Care Information System from Sam Hall, timelines continue to be very challenging. They always have been, haven't they, Sam? But there's a plan and there's a roadmap and there's a close dialogue with government on that. And then finally, we have 3 programs that are in a red rating in terms of their delivery confidence at the moment. The first is Welsh Intensive Care Informatics System. There's a review or there's an update on that coming up later on the agenda today. So we'll have time to go into that in more detail. Cancer Informatics Solution, I think I suggest that we dive into that a little bit further when we get to the assurance slide. For cancer, there's one risk which I'll cover in a moment, which is in the cover sheet. And then the eye care programme as well. Similarly, we'll cover that as we get into the assurance slides. And Sam will speak to that about where we are with that programme. So overall, we've still got a lot of, you might say we've still got quite a lot of red, and we've got a lot of amber red. It's fairly stable. So that is, we haven't had a lot of things that have moved into the red space. We know from, well, committee members will know from the conversations that we have at the main SHA board about the pressure on resources and about the pressure, and the pressure on resources doesn't just mean money. And there is pressure on money, as anybody who reads the news and listens to the news will know in the NHS context. But that pressure is also pressure on people. And all of these programs are delivered by people in our own organisation, but out across the whole of the NHS. It's an extremely congested delivery timeline at the minute. Just to take 2 closely related examples in diagnostics, delivering the LIMS and the RISP changes simultaneously across the whole system in a very short period of time is a really, really challenging thing. And we have several other things going on at the same time. So we're working closely. We review monthly with each health board what the implementation pipeline is. But I think that would be my take on why the portfolio is, if you look at it as a portfolio, why it's in the shape that it is in terms of the delivery confidence that each of the individual program boards is reporting, is because there is a very significant pressure, and I don't see that that going away anytime soon. On the people and the money that is needed to make this kind of digital transformation happen. So we're really focused on understanding it, managing it best we can, mitigating, and trying to be as lean and as efficient as we can in various places. And then finally, I'll just say, and then we'll pause for questions and comments before we go on to the individual slides. We are raising one escalation to the committee, which is to do with the Cancer Informatics programme. And particularly, we've submitted a bid to the Welsh Government with their agreement for additional funding, and we've been given an indication that gives us a reasonable confidence of receiving that additional funding support through into next year. We've not yet received the formal confirmation of that funding, and if that funding for any reason doesn't come through, then as an organisation, DHEW will need to find those costs from its own resources, and finding several millions from our own resources at this quite late stage, just before the next financial year, is going to be extremely challenging for us. So it's escalated to the committee because the impact of what's happening in the program's environment, and there's a potential risk here that would roll over onto the organisational context and our core funding position, because we will need to shore up the program's delivery from the core funding position. So we're raising that to note as advice, not for a particular action here, but because it's important. Hopefully it will resolve within the next few weeks. But we thought that was something that we needed to escalate. So I'll pause there.
Okay. Thanks for the escalation and the timeline for hopefully trying to resolve that. So hopefully it's no further than a couple of weeks. I'll just open up for questions if anybody's got any on the overall summary that Evan's gone through before we dip into a little bit more of the detail. I know you've done too good a job, Evan. We're all good to go. So if you want to press on with the slides.
That's great. Well, so we'll just take them in order then. Shall we, David? And
yes, please.
Do you want me to sort of give an update on each one, or just put them up? So the first one is the National Data Resource. So I'm speaking to the NDR slide. Is it best if I try to anticipate questions, or that we just invite questions?
I think for the benefit of the public who might be watching this, I think it'd be useful for you to put the slide up and just pull out a couple of key points as you see it, that things that the committee might want to be aware of or ask questions around. So if you could do it that way, I think that would benefit not just us, but the wider public who may be just watching.
Yeah, I'm. So I don't know if anybody has got the slide deck ready that they can put on screen. I think it would probably be helpful to put these up on screen. I'm looking at it in a browser, so it's going to be a bit messy if I put mine up.
Give us
Laura or Chris, are you able to have?
Yeah, we'll get up in a sec.
Yeah. Okay. Great.
So, well, if we do that then, so I'll just give, while that is happening, I'll just give a quick update on what the NDR is as a reminder for, and I hope that the public do listen to these meetings. There's so much which is, exciting and important, which is happening at the moment. And I think the NDR is one of those. It's an enormous part of our ambitions for the future. As you can see, if you look at the strategy that was signed off by the board a couple of weeks ago, this is our future data fabric, and this is where we want to hold all of the data that relates to healthcare delivery, but also to understanding the way that healthcare services are delivered and research and various other things. So as a single platform, this is a fully modern cloud architecture. It's a very large program. It's currently coming to the end of its 5th year as a program. And the first 4 years have been, we were sidetracked a little by the COVID response and building a Welsh pandemic record and all the data that was required that underpinned the COVID pandemic for about 18 months. But we learned an enormous amount from doing that. It was almost like an NDR, minimum viable product, and we learned a great deal from it. So there are 4 main elements to the National Data Resource technically. There's a care data record, which is the main direct care element of it. There's an analytics platform, there's an API management platform, and there's a secure data environment, which is for research purposes. And then alongside that, there's a piece of work around advanced analytics skills. That is the people skills that you need to get the most out of the platform, the technical platform that you've built. It's halfway through the phase 3 business case. We're working very closely with Welsh Government on the phase 3 business case, and as you can see from the timelines and the rating, it's pretty much on track. The only thing the other thing which I'd pop out is that this is the most federated of all of our programs. There's a very strong health board representation, and it is a very strongly collaborative, almost syndicated program right across the whole of the NHS landscape, as well as the National Data Resource. Each health board has got what we call a local data resource, which is a part of the National Data Resource. So there are a lot of moving parts. It's a very significant amount of money. It runs at 7 million a year or so, or thereabouts. But it's making good progress, and it's getting a really good buy-in and support from our key stakeholders and delivery partners, which is really good to see. So there's nothing which I want to escalate particularly or want to flag. Yeah.
I've just paused to see if anybody's got any questions. Marion.
Thank you. You mentioned earlier, Ivan, the recruitment challenges, and the importance of understanding those challenges, managing and mitigating them. What's your level of confidence that we'll come through and be able to respond positively to those challenges?
Difficult to give. I would say medium high. So before Christmas, I think the focus was on our ability to run there's 15 or so posts that we're looking to bring in. Our ability to service that on top of the other posts that we need to recruit in other places. So the NHS Wales app is also recruiting heavily. We've got more than 10 posts going out on that at the moment to recruit a new NHS Wales in-house app development team, and that puts a lot of weight on our on the DHCW people and OD function. I think the risk now is whether we're able to source the talent that we need from the wider market, and whether we can do that without cannibalizing either our own people or health board staff, and then we're robbing Peter to pay Paul, as they say, and creating holes elsewhere. I think that the NDR brand is more and more widely known. People understand what it is that it's doing, the technologies that it's using to do that, and I think that is very attractive to the sorts of engineers that we want to recruit, which is why I'm in a sort of a medium-high confidence space.
Yeah.
Thanks, Marion. Thanks, Stephen. Okay, I can see no further hands, Stephen, so if you want to move on to the next one.
So this one is for Sam.
Thanks, Ivan. Yes, so this is an update on the Welsh Community Care Information System. So many of you will probably be quite aware of this programme. It's been running for quite a long time now. I think it's probably in year 7 or 8. So it's a long-standing item in our programme, in our portfolio of programmes. Earlier this year, no, not earlier this year because it's 2024. So towards the end of last year, we took a proposal to Welsh Government that we needed to update the system. It's coming to the end of some of the contracts that we have for it, and also there are some long-standing dissatisfaction with the current system that we use for several reasons, but uptake has been sporadic across both health boards and local government organisations. The proposal we took to Welsh Government was that we needed to move away from this very traditional approach of a big monolithic system that tried to do everything, and to approach it in a different way. So there are 3 elements to where we're moving WCCIS onto, and including a change of name. So we'll be taking the programme forward into the name Connecting Care, because that is actually quintessentially what it is. So whilst we are still running the service on the current system, and we will be for another year or 2, we're also starting the programme, which is what much of this information is about, to look at the Connecting Care elements. The 3 main elements for it will be a shared care record. So that's across social care and health, because many of our citizens pass between these areas quite frequently, and people need to have a joined up record of that interaction. Also, we needed to start to design some of those data and digital pathways that people follow, so that it was very clear who needed access to what information, and also that information followed the patient where it needed to go. And then thirdly was actually the systems themselves. So as I said, we have currently one large system supporting health and social care, but the approach we're looking at now is, well, what would be best for those for each of those areas? So it may not be that the social care system would support health and vice versa. And also in Wales, we've got a requirement to look at mental health as well. This is something that is quite, there's no uniform approach, I think is the best way to put it, across Wales, and there are lots of kind of small systems working on it, but there's no holistic approach to that kind of cross Wales support for mental health. So where we are currently is we've we've done some initial findings. We've done a discovery on mental health to set direction. We've done some market engagement to look at some of the systems that are supporting social care, and we'll move on to health as well to look at the health systems. We've done some really extensive engagement with our stakeholders across health boards, lots of conversations with and looking at systems being used in our neighbouring countries to see what they're using and how those are being utilised. So we're in the position now where we are drafting a full business case to show where we need to be going in the future with connecting care, whilst at the same time pursuing our exit negotiations with the current supplier. And that's going to obviously pick up pace now. It's going to be very intense and quite a lot of work for the programme team to do this. And we suspect that it will be, I think the challenges will be, as mentioned in every other programme at the moment, is financial, and how we will make sure we can afford to do this work quite speedily, because as I said, we've got some contracts that are coming to an end, but also we have an absence of a system for mental health in many of our health boards. So that is it's a really important piece of work to try and solve that problem and to get something in place that are that really supports our patients, but also is useful for our clinicians to be able to do that. And in many cases, it will be quite a seismic move away from paper, which is still being utilised in lots of areas of mental health. So that's the quick overview. But as I can see, it's quite an intense period of time in this on this programme.
Thanks very much, Sam, for the update. Ruth, I can see you've got a question.
Thanks, Sam. WCCIS is one of my favourite topics, as it's been such a priority over the last couple of years, certainly since I've been on the board. It's certainly the thing that I've received most feedback about. I think for the first time, it feels like we're actually starting to get our arms around this and understand what really needs to be in the programme. So just two questions, Sam. I wonder if you could spend a little bit more time talking about the stakeholder engagement that's been done on this, because certainly from my experience, when we've received feedback in the past on WCCIS, some of that seems to come as a surprise to us, and I think there've been gaps in our engagement, or certainly we haven't had a flow of information back to the programme in a way that works as well as it should have done in the past. So I just wonder if you could talk a little bit about that. And then the second general comment is, I think the work within this programme is so important, but it could be everything. I mean, this literally touches all parts of the system. So how are we really challenging what's in and what's out? Because I think we do run a danger as we start to get our hands around this and be more successful with our engagement, understanding what needs to be done. This could just grow and grow and grow and grow and grow. I think the potential for scope creep here is massive. So how are we challenging ourselves on that? Thank you.
Yeah, thanks, Ruth. Good questions. So the stakeholder engagement, we started that off as we moved to Connecting Care in the last quarter of 2023 with regional meetings with all of the stakeholders. So that's their local authorities and the corresponding health boards. So they were face to face. We went on the road, and they were face to face meetings to take them through all of the options that we had, what we'd looked at, and actually run through from where we'd got to. So a lot of the decision making around this and how we'd come to the proposition that we'd gone back to Welsh Government with was based on a lot of strategic reviews, which they all fed into. So it wasn't a bright idea from from me or the team in DHW, this was boiled down information that all of our stakeholders had fed into in those strategic reviews. So, that engagement had been quite intensive, and so we wanted to follow that up with these face-to-face workshops. And then since then, we've got a newsletter that's going out that's updating everyone on the work that's going on, both on the current platform but also on the new work. And we've set up a project board, and we've got representation from local government, health boards on that new project board. It's not a full programme board yet, as this is still kind of fact-finding around Connecting Care, but obviously at some point it will flip into becoming the new programme. And so we've got representation on there, not just from the health boards and local authorities, but also from social care, from nursing. So it's quite a very, it's got a broad scope. So that's happening as well, and those meetings are I think every fortnight at the moment, so quite intensive. But also that leads on to the second part of your question, which was how do you account for scope creep? And by the amount of people that are interested in Connecting Care, you can see that when we were first looking at WCCS, it was very much around social care and social care pathways, and where they really linked in with health and the community health space. We're already including in that now mental health. So that's a bigger ask than we originally were working on in WCCS, where mental health had only been, the mental health module had only been rolled out and was only being used by Aneurin Bevan, and that's fairly recently. So looking at a completely different approach to that mental health management is already a departure away from, I think, where we were when we were looking at the modular system in WCCIS. So that will be part of our business case. This is as far as we need to go. That will be the edges of the programme, which is the health and the community health care, the links with social care and the social care system, and then the mental health. That's as far as we've looked. That will include some of the things which are which should, again, probably arguably should have been delivered through WCCS, such as district nursing, health visiting, and things which come up constantly in primary and community care spaces. Those are things that we're already doing discoveries with, along with AHP, which is the Allied Health Professionals. So those are our folks that are out there working in health, clinical roles and therapy roles. So, our occupational health visitors, physiotherapists, and other kinds of therapists. And we've done a big piece of work looking at what that requirement is. But that doesn't mean that there'll be new systems for everybody. This will be, what do we get, which is the best thing? How do we link the best thing based on those digital and data pathways, that we can share the record in the most efficient way with the fewest number of systems possible? Because actually that's one of the other things that comes back, is the more you add into the mix, the more complicated it gets for users. Mm. So we've got a couple of things that we need to kind of to work through with that, but our business case will put the edges around what it is we're looking at, because you're quite right, it could literally grow like a weed a little bit.
Okay, Sam, and appreciate you getting your arms around this and navigating a way forward. So look forward to further updates and hopefully a repositioned programme. If there's no further questions on this one, I'll move us on to Digital Maternity Cymru. Even, or you handed over to Dave for this one?
I'll lead on this one.
Okay.
Chair, thank you, and then colleagues can come in if there's anything to add or which I've missed. The reason this is with the RAGS data set it has is because we've deliberately taken the choice to pause to give ourselves a bit more time to do more planning and more engagement and other work. And I like to think that this is the first time really we've got an opportunity to firstly apply lessons that we've learnt from the programs that we've taken on or inherited or been transitioned to us through 2023. Some of them, very large, complicated programs, Link as it then was, which is now LIMS 2, and RISP and Digital Eye Care. And secondly, we also have the benefit now of our Portfolio Management Office, which is established, and some stronger patterns around the way that we report and for governance, and the Welsh Government has changed its governance arrangement, so we have programme oversight chairs. So back in the autumn, we took a decision not to, although funding is indicated from Welsh Government for the first few years, not to plough straight on, but instead to take some time to be more thorough in our planning and in our preparation. And I think that is a good discipline, which I want to highlight to the committee, because I think the committee can take more assurance if we're putting more time into that early planning. If you come across unexpected things while you're planning, it's relatively cheap and simple to fix them. If you come up against unexpected things while you're in the middle of delivery or halfway through delivery, then it's much more complicated and more expensive. So really we want to get through the delivery phase as quickly as we're able to, because the quicker we get through it, the less time there is for unexpected things to come and derail us. So on this programme, we're working really hard. We've revised the programme, the outline business case. We've done value engineering on the business case and taken at least 20% out of the cost, which was quite significant. So I had deep conversations with our key delivery partners and with health boards about their expectations and their commitment. You can see on the slides that is on screen, we've done some proof of concept work on standards. We're doing some additional assurance on technical and clinical matters. So trying to get as much of that out of get that done solidly before we go into the delivery phase. That means that we are behind the original intended timeline, which was set at a really, really early stage. We still haven't formally submitted the outline business case to Welsh Government. So in some senses, this programme is in pre-delivery phase. But I just want to highlight, make it really obvious to the committee that we are we're trying to apply lessons that we've learned in order to put more effort into that pre-planning phase, in order to bring more out of the woodwork so that we can deal with it before we get into delivery. And hopefully that will then enable us to get through the delivery with more certainty and with more pace, and therefore to deliver better value for money and to have more certainty around benefits and timeline and delivery confidence. So that's where we are on digital maternity. The programme board is meeting on Thursday to review the latest draft of the outline business case. So we're making good progress on that, but it is, we've deliberately built in more time for ourselves than was in the original timeline.
Okay, thanks, Evan. Would commend the approach you've taken. I think it is better to spend a little bit more time addressing those issues and get the stakeholder buy-in before we sort of formally launch. So I'd commend that. Anybody got any questions for Evan on this particular one? Okay, just for the record, this was one of the topics that we covered in the private session, so there was a little bit further discussion around some of the sensitive issues on this in the private session. So if we move on then to LIMS.
So I'm handing over on this one to Michelle.
Thank you, Evan. So Michelle Sell, I'm the Director of Planning, Digital Health and Care Wales. So quick update on the LIMS. So this is our laboratory system. This is the system that operates across all of the laboratories across the NHS in Wales, who are basically assessing and reporting on a range of diagnostic tests. So this is quite a key system in NHS terms, that underpins a lot of the activity that the hospitals would undertake on a day-to-day basis. So this is the new system that's being rolled out again, a national system configured once in a consistent way across the whole of the system. We took a change in direction on LIMS last year. We had to invoke our contingency plan, which has meant a different approach with a different provider. So the consequence of that really, well, two things I want to say. One, progress has been excellent. So the programme team doing fantastic work with the wider NHS team. So there's quite a lot of resource involved in this programme, and are really making a significant amount of progress. So that's on a positive note. And I'm really pleased to say that we are on track. We're a little bit ahead of delivery actually in terms of some of the supply delivery, but we're on track to our first go live, which is in February 2025. So we've got about 12 months now as a run-in to complete the configuration build, and there's quite extensive testing on this system as well before we start to use it within the hospitals. So the other key thing probably to flag is we've got a very detailed implementation plan, which includes the rollout plan, and that's been shared with all of the health boards and trusts across Wales, and they have included within that is an indication of the level of resource that they need to provide. So there's local testing that happens within the hospitals, for example, which is undertaken by the teams at the hospital level. And the organisations are working through the implications of that. So the main reason for the amber red there is that a couple of health boards particularly have flagged that they'll need to address those resource challenges. And we're managing that through the programme board, and they're escalating that within their own organisations, that this is something that they will need to do because there are certain tasks that have to be done locally. So that's the main issue there. The other, probably on scope, is because of the change in direction, this is a very rapid development. 12 months sounds like quite a long time, but this is a significant system. It's a rapid development and rollout, and that means that some difficult decisions are having to be made around scope. So we're not missing any key functionality, but there are some aspects that we'll need to make decisions on as a system. And one of the decisions that they're working through at the moment, for example, is around the legacy data. So the amount of data we take from the old system into the new system, which has a knock-on effect then to the amount of checking that has to be done locally. So that's something that they are working through in the programme at the moment. So I was going to stop there, but happy to take any questions.
Thanks, Michelle. Really good progress, and delighted to see the team implementing the new plan that you've put on the table. Any questions from the committee? Okay, I'll just ask one if I may, Michelle. So with regard to the resource constraints within the health board, which is one of the issues you've flagged, when do you think we might get a resolution of that? And is there any likely impact on the rollout programme we've got?
Yeah, so it's because of the potential impact, David, that we're watching this quite closely, as I said. So what happens now is all of our health board colleagues bring update reports to the board. So the board meets on a monthly basis, and they all bring their updates. And I think resource is a challenge for everyone, not necessarily just for the people who've been identified, but what organisations are doing is putting forward requests inside their own organisation for additional funding or additional resource at the time that it's needed. So we're not worried about this today, because the reality is a lot of these resources are needed probably at the back end of this year or early next year to support the rollout. But we are trying to be on the front foot with this and make sure that this is covered off well in advance. So I expect it'll be raised at the next board, David. And if it's not resolved, then the board chair is really good. He'll be looking for a confirmation then that it has been escalated and then it is being addressed at a more senior level within the organisations.
Okay, excellent. Thanks, Michelle. Any further questions on this one before we move on? Okay, thanks again, Michelle. And I think we're back with Sam for the National Digital Eye Care Programme update.
Hi, yeah, thank you, Chair. So this is the the Eye Care Programme. This started to move to DHW in summer 2023, having been previously hosted by Cardiff and Vale University Health Board. So we started the transition work and have done lots of extensive review into the technology, also the financial situation and the contractual obligations around the current instance of this, which lives in Cardiff and Vale. So that's been done. Towards the end of last year, as Yvonne said at the beginning of this session, when governance changed, so the governance had been at Cardiff and Vale through a programme board and an SRO. That has now changed in November, and we are currently setting up the programme board from DHW. We have two clinical advisors that are joining us and joining that board, one for ophthalmology and one for ophthalmology. We are yet we don't yet have a chair for our programme board, and we're hoping that that's going to happen in the next month or so. So excuse me, there's been some very loud noise. I'm not sure you can hear that, but here there's some drilling going on outside.
That's okay.
Yeah, and sorry about that. And so we're hopeful that we'll get a chair appointed in the next month. And so where we currently are is there are three main elements of this program. One was the provision of 365 licenses to ophthalmologists working in the community, the primary care element of this. We've taken that out of the programme to be able to deliver it more rapidly as part of the 365 rollout, which happens wider across NHS in Wales. And then the two other elements, one is a referral system, and then there is the real kind of secondary care element around electronic patient records, and the system looked to support the really kind of serious situations in eye care, such as glaucoma and medical retina and other areas. So that's the scope currently, those two elements. And where we are, where we currently are on the programme is we are going to, we've already submitted some options for going forward on the programme. There are 5 options, but we have to work that up into a recommended option by the end of this month, which will go back to our programme board and get submitted to Welsh Government, where we will be looking for agreement around funding, so around the funding for us to be able to take forward that option, that recommendation. Until then, we are still in that kind of transition, understanding the contracts, understanding the technology, and meeting with our all of the stakeholders and the health boards to really kind of clarify their requirements and timelines. But until we know whether there is funding available for this, which obviously Welsh Government are waiting on our recommendation at the end of the month, then we are a little bit, which is why everything is red across the top of of this, is because we can't actually progress until we know that recommendation is acceptable and that funding is available to do that.
Okay. Thanks for that summary, Sam. Any questions for Sam on the eye care programme? Marion.
Thank you, Sam, for that very clear update. As we well know, the transfer of many of these programmes are inevitably challenging. We are inheriting legacy programmes, and probably just worth, for the record, just reminding colleagues that the Audit Committee has commissioned an internal audit into the National Eye Care Digitisation Programme, and we are expecting that to be delivered by the end of this financial year. So that should give us a helpful indication of formalising some of those issues that perhaps we may not currently be fully aware of, although I'm sure from the work that you've outlined, we have a pretty clear handle on what to expect. But I think that internal audit would help us get that external view of progress and issues and challenges going forward. So within a few weeks, certainly, we will have that coming to committee. Yeah.
Thanks for that update, Marion. Much appreciated. Any further questions for Sam on this one? Okay, thanks again, Sam. Much appreciated. Let's move on then to the Bridgend transition, including Welsh PAS system. Even is this you or David?
Well, it's David if we're presenting it here, but we've got on the agenda, we've got a deeper dive into both PAS and then WCIS. So
fine. So let's skip over
you agree,
those
I think it's best to leave it to that.
Yeah, absolutely. Yep.
And this one is for Michelle Risp.
Okay.
Yep, thank you, Ivan. So yeah, quick update on RISP then, for the benefit of those who aren't familiar. So these are our systems that we use in radiology services. So picture archiving. So that's basically a system that stores distributes and shares images that are taken from the various scanners within the hospitals. And the radiology system that sits alongside it is the system that's used in basic terms for scheduling that work and for appointments. People may be called in to have various scans or images taken. So those two quite big and quite fundamental systems again. There's also some patient dose management in relation to X-rays that are provided. So timescales are tight on this programme. As we know, this is a programme that came into us at the beginning of last year. Hence, this quite challenging, both centrally and for the health boards. Health boards all have their own contracts that they've entered into with the supplier in order to deliver this, and their own plans at a local level, because they're all at slightly different stages in terms of how this rolls out. Our role as an organisation is to coordinate that centrally, and there are obviously central activities that also need to be completed. And that really leads to something I wanted to flag to the committee, which relates to that kind of national overall plan, which is really important that we have that understanding and we're all confident that that can be resourced and delivered. So we had the programme board last week and we discussed that at some length, and we also discussed it with the supplier. So we don't have that plan. They haven't been able to deliver that joined up plan yet, although we have received assurances that will be delivered in the coming weeks. I think that's quite a key deliverable for NHS Wales, actually, from our perspective. So we really need to see that. And we have escalated that with the supplier in terms of the expectation that that is provided. So each of the individual organisations will have plans. I'm not suggesting there are no plans, but pulling that together into an overall view and ensuring that everyone is confident that can be delivered is really important. So just wanted to flag that up specifically. Again, timescales are tight. So the first organisation, Public Health Wales, are going first in November of this year. So that's the kind of turnaround that we're talking about. And again, there's quite a significant overhead here in terms of data migration. So all of those images that have been gathered over a number of years will be moved into the new system so that they can be accessed by clinicians as and when they're treating patients in terms of what's been done in the past. And also there's quite a lot of work around standardisation. So again, we're trying to deploy a standard solution across the whole of NHS Wales. So there's quite a lot of work to be done to ensure that that's achieved. I think the other positive thing for the purposes of the committee, just to highlight, we've also had good conversations in the board about the benefit of acting collectively as NHS Wales, and are firming up some of the thinking now around collective service management and contract management, so that we can make best use of the resources in the centre. So an organisation like Digital Health and Care Wales, who's able to call on that kind of expert resource to coordinate that, working really closely with colleagues in all of the hospitals across Wales. I think that's really important in terms of how we move forward, and that is something I said that we've been discussing and now firming up in terms of the plans for as and when the service does go live. Happy to take any questions, Chair.
Okay, thanks for that update, Michelle. Quite comprehensive. Any questions from Michelle on RISP? Okay, I can see no hands. So, Michelle, the only thing I had, which is a recurring theme, is we are rolling out across the health boards, not just RISP, but LIMS and a few other programmes. So we will need to keep an eye on the ability to deploy in the manner that we've got planned out at the moment, but I'm sure that's something that's front and foremost in your mind, so we'll just keep an eye on that going forward. Yep, absolutely. Okay, thank you for that, Michelle. Next up is Digital Medicines Transformation Programme, or Portfolio, sorry.
Thank you, Chair. This one's for me. So as I mentioned earlier, this is the only portfolio arrangement that we have within the wider DHCW portfolio management programs. And our main focus over the coming months is going to be on ensuring a smooth transition from the existing portfolio governance to being part of the wider portfolio management office. The portfolio is made up of 2 programs and 2 projects. So there are 2 larger programs, the EPMA program for e-prescribing and medicines administration in hospitals, through which health boards are each procuring their own EPMA provider. Then all of those use common standards and APIs in order to write data back into the record. That is making good progress, and they're all on track and on timetable with their procurement processes. These are large, complicated procurement processes, but they're all on track with those. And Welsh Government is starting to confirm the funding arrangements to those secondary to the health boards that earliest, I suppose, in the timeline there, and we'll follow through on the others we expect. And then the e-prescribing, the electronic prescription service in primary care, mentioned earlier around the service proof of concept. Like programs like the NHS Wales app, we're going through a sort of an initial technical proof of concept, a service proof of concept. We validate that at small scale, and then we scale it out to more providers, more GP services, and more pharmacy systems. That also is making good progress, starting from real and is expanding on track and on timetable. And then we have two smaller projects: patient access, which is functionality within the NHS Wales app, delivered through NHS Wales app work packages for prescription ready and nominate a pharmacy. And then the shared medicines record, which is closely aligned to the national data resource. That is a consolidated record of the medicines for each individual for direct care purposes, held as part of the NDR fabric. So all of those programs are doing well. Our focus is on providing as a really strong reassurance to everybody who's been involved in the delivery of the medicines programs that we do not want to destabilize delivery as we transition from the existing governance arrangements to the new ones. And nor do we want anything to slow down, because the delivery has been really good and really quick across these 4 different areas. And the portfolio board and leadership has done a really good job of that. And what we want to capture is, as well as a smooth transition, is the strategic oversight that they have. And you can see on the slide in front of you things like closed loop medicines administration and some other things. You don't want to lose those as we move from one place to the next. But the thing that I want to emphasize most is that the programs will continue to deliver in the way that they do. The teams will continue to work on the programs that they are working on, and we want to continue the delivery without a hitch right through. So that's what we're focused on over the next 3 months, and that change happens at the end of March in around 8 weeks.
Okay, Evan, thanks very much for that update. Anybody got any questions on this topic? Nope, I think that was a really good update, Evan. So we can move on to the Cancer Informatics program. Sorry, you leading this, or is it David?
I am like the quickest fly half in World Rugby, and I'm passing it straight on to David.
Okay, good man.
Thanks, Evan. David Sheard, Assistant Director of Service Transformation. So the objective of the program here is to replace a legacy cancer system called CANISC, which has been out of technical support for some time. And just to note that we've already discussed earlier in the meeting the escalation regarding funding for next year. But as it stands, we in DHCW, the project team, are proceeding on the assumption that the funding will be secured and for next year. And the scope of that funding covers the completion of the essential system user requirements in order to decommission CANISC itself. So the history of this project is long, and much of the usage of CANISC stopped last financial year following delivery of phase 1. But there are still some remaining elements, and that's A, what we're working on at the moment, and B, what we're trying to secure the funding for to complete next year. So I'm going to spend a little bit of time just talking about the two main areas of functionality there. Firstly, palliative care. So there's a palliative care module within CANISC. This is now all elements of the PAL care functionality are now all available for test with the health boards. So we have made some progress here. Obviously, we need to get through UAT, and then it'll be ready for deployment to the health boards. The second big chunk of functionality that remains is called screening and colposcopy. We've struggled here around the design of screening and colposcopy, particularly around the imaging requirements. So the legacy solution stores images locally, and it's not something that would be appropriate going forwards. So the design for screening and colposcopy is going through the new technical design assurance group at the moment, and it's expected to include a design that includes storing the images in the Google Cloud platform that has come on board since this project and programme was initiated. The deadline to turn off CANISC, i.e. to decommission it, has been set for later this calendar year. And we need to get palliative care screening of colposcopy through the door, out and being used before that can happen. But they are the two major pieces of work to enable that. Finally, I was just going to mention in terms of governance, Tracy Cooper, who is Chief Executive of Public Health Wales, has been the SRO on this piece of work for several years. Due to arguments, she has stood down, I think, and we're just waiting for Welsh Government to confirm a new SRO there. And that was all I was going to say. Happy to take questions.
Okay, thank you, David, for that update. Anybody got any questions for David on Cancer Informatics Programme? Okay, so I'll just clarify. So we're obviously waiting on funding coming through for this. Can I just check that if that occurs as we hope, we've got the resources to deliver the programme that you've just talked about in terms of decommissioning the old system by the end of the year? Michelle, do you want to come in on that? Oh, sorry, David. Oh, Michelle.
I don't mind, David. Thank you, other David. So we've actually taken action as an organisation to extend the resources over that period because of that risk, David, which is clear. We didn't want to lose people. Yeah. So that's a risk for DHCW or a cost to DHCW if the funding doesn't come through. But we were keen to ensure that we had the team in place. And as I say, work is just carrying on while we resolve the funding position. I think that's quite important that we carry on doing that.
No, I fully agree. And from what Evan said earlier, when he raised this in escalation, we are only talking a matter of weeks, hopefully, before we get clarity on the situation. Great. Okay, excellent. If there's nothing else on this, we'll move on to DSPP. Evan, are you taking the lead on this?
Yeah, I am taking the lead. I'll just add to Michelle's comment. So, so committee members will know we've discussed at the board that we recognise talent as one of our biggest risks as an organisation and people. So we are, we made that decision because we really need to look after our we need to look after our people, and we need to show them that we've got confidence in them. So I think it's absolutely the right decision that we've made there. Although we recognise that there is a potential risk, but hopefully one that that won't be realised. On DSPP, so we had an update at the last PDC on DSPP, but just to refresh people's memories, or if they're watching for the first time, this is another programme which is going at quite a clip, quite a pace to develop and deploy a new NHS Wales app. It's just over 2 years in, really. It spent the first year doing its design and development work and re-architecting the code base that we took from the NHS app in England. There were a few enhancements that we wanted to make to that, and getting through a private beta program with around 700 people providing specific feature feedback and various other things. Around about 10 months ago, mid-April last year, we started the public beta phase, which was the first time that the app was available in the app stores on Apple and Android, so that anybody could download. So the core feature functionality of the app is available to anybody who downloads, but there are other features, ones highly valued by users, that come from the connectivity, from connecting GP practices and the services that GP practices open up through the app. During this current year that we're in, that we're just coming to the end of, this is about scaling up within the public beta and getting all of the GP practices connected. So we're more than halfway through on that. We've got all the EMIS practices in Wales connected. We've got a plan for getting the SEGDIM practices connected before the end of this financial year, which is before the end of March. So that will happen over the next 6 to 8 weeks. And we're on track with that work. And there's really good collaborative working happening with primary care teams and with teams in GPs and practice managers, and a very large community for what is quite a complex exercise. It is still really, really busy. And so the first year phase was development. The second year phase was fill out the connectivity, and then the third year will be about expanding features and various other things. So what we're working on at the minute is work package 10, which has got some things around medicines and pharmacies, so prescribing in primary care. It's got an offline. We use NHS Login, which is a England and Wales service provided by NHS England for identifying users in the app. More than 1.3 million people already registered on NHS Login in Wales. There are two ways to register if you're not already using it. One of them is an online process where you show your passport or driver's ID, and it takes care of it that way. And then there's also an offline verification service. Because of the way it's configured, the offline verification service that is available in England can't be used in Wales. So we're developing our own. That is in Work Package 10, and we're hoping to get that there quite quickly. And then proxy access, so that you can access the features in the app on behalf of a third party, is another thing that we're working hard to develop quickly based on the feedback that we're getting from users, because we are in a public beta phase. And then the two other things that we're working on, one is on the business case to seek continued funding for the NHS Wales app from March 25 onwards. So funding is confirmed by Welsh Government for another 13 to 14 months. But then we need to submit a further business case. So we're in the final stages of completing that work at the moment. And then we are just about to, or just have, I'm not sure of the dates, go out to recruit an in-house team, an in-house product team to maintain and run the NHS Wales app. Up until now, we've worked with a supplier partner, a company called Kainos, who have done the development work for us. We manage them under contract. We own the code, but they develop it for us. Where as a next stage, we're now building a team, an equivalent team inside our own organization, which will initially run alongside Kainos, and that will enable us to transition and to take full ownership of the code base. We will still have the option of working with external partners to bring them in to accelerate development and various other things. So I think that's quite an exciting development for us. If you're a developer watching this committee, then well done you. But this is a really exciting opportunity to be part of the development team for the NHS Wales app, working with DHCW, which is the best place to work in IT in the UK. So it's really exciting, I think, for the DSPP app and the NHS Wales app. And I should say that the numbers are ramping up quite rapidly now. And I think over the last couple of weeks, we've just gone through 100,000 users of the NHS Wales app. So it is moving rapidly.
Excellent. That's some really good news in there, including the advert for anybody listening who wants to come and join us. So thank you for that, Evan. Anybody got any questions for Evan? Can't see any hands up, Evan. So, oh, Marion.
Yeah, thank you, Chair. Evan, I just wanted to congratulate the team. I mean, it's great progress, and it is very, very exciting and a hugely important development for the people of Wales. But the success of the app will ultimately depend on the primary care family engagement, if you like, and to what degree they're going to be prepared to sell the enhanced features. So what's the process for securing primary care engagement, and when will that process begin to ramp up?
Well, I think maybe I'll give a preamble and then let Sam Hall maybe come in if she wants to add anything. We manage, DHCW as an organisation, manage all of the IT and digital services in primary care. And unlike England, we've got a close relationship with primary care practices in the digital landscape. We manage everything, the desktops, the printers, and everything else. So the approach that we're taking is to not try to establish a direct relationship alongside that between the NHS Wales app programme teams and primary care, but to work through the existing relationships that we have. And I think that's the right approach, and it enables us to calibrate what we're asking of primary care and to understand what their concerns are and what the barriers to adoption are. So we're providing lots of information, lots of education and support. That, as an example, the DSPP programme team are very proud that a couple of weeks ago, in 2 days, they delivered more than 500,000 leaflets out to every GP practice in Wales to support users, their patients, to transition to the NHS Wales app and to adopt and to download it and various other things. So there's close working going on. Sam is probably better placed than I am. But, my take is that it is already ramping up. And the only thing that I would add to that is that at the moment, our priority is on primary care GP practice features in the NHS Wales app, because that's the route that NHS England has taken, and that's what patients expect. And you might have seen some news coverage yesterday on on what is happening in England, and that often drives a lot of the UK understanding of where these things are. But the app is more than just primary care, and there are other features. And right now we're doing an accelerated discovery sprint with the planned care programme around a whole bunch of areas in secondary care. And we'll be trying to bring several of those features on stream over the next 12 to 18 months. So primary care is really, really important to us, but it's not the only thing that the NHS Wales app will be able to deliver.
Thanks, Stephen. Marion, no further questions? Great. Okay, thank you. In which case, Evan, I think that concludes the programme overview part of the agenda. So unless you've got anything further to add, I'll pass over to Chris. And Chris, can you take us through the item 3.4 corporate risk register?
Yeah, thank you, Chair. And just one terminology point. David referenced in the cancer the transfer from SRO to SRO. It's transfer from SRO to the programme oversight chair going forward. Just to confirm that, because of the Welsh Government changes Ivan mentioned earlier in terms of programme governance, probably important just to be clear on that. In terms of the corporate risk register, there's 19 corporate risks that DHEW have. There are 5 allocated to this committee. 2 of them were considered in the private session earlier this morning that aren't featuring in the public papers. There are 3 public risks assigned to the committee. So I'm going to run through these. There's 0269 switching service data warehouse. And last week, the Digital Governance and Safety Committee heard some work that helped the resilience of the current switching service. This risk in terms of mitigation is very much around the future and when this will be taken on by the NDR. So I think it's looking for timeframes on the roadmap. So I'll see in a second if there's an update from Ivan in terms of specific timeframes. The second risk is 0332 Sustainable Major Programmes Funding. And it's worth this committee noting we have incorporated a number of previous corporate risks that we've put at directorate level now into this one overarching risk. I think this is significant from a portfolio perspective. There's an aggregation of risk, particularly in the current funding environment within which we're working within. So a number of the major programmes currently have uncertainty, and that's aggregated into that risk there. And then the final one, 0333, David, I think, took us through earlier in terms of the intensive care system and the implementation delays. So wasn't planning to cover that because I think David covered that through the update. But I will just look to Ivan if he wants to expand on the NDR roadmap timeframes and the switching service, and secondly on the programme funding.
So I haven't got a specific timetable, but I'll just give a quick update on what is happening. So the switching service is a mechanism for providing data or for extracting data from our live systems into our data warehouse, which is what we use in our information services department as the basis for our analytics reporting, statistical reporting, and various other things. The NDR environment is live since August. And the data warehousing environment is now closed to new data feeds. The existing data feeds continue to run into it. The switching service continues to run into it, but it's closed to new data feeds. New data feeds will be going directly into the National Data Analytics Platform, the NDAP, in the NDR. And the ISD team, led by Rachel Powell, is working very closely with the NDR team, led by Rebecca Cook, to start moving data and existing data feeds from the old data warehouse environment into the NDR. So as that happens, that will effectively take out the switching service. So rather than, and this has always been our intention, that we will effectively deprecate the need for a switching service because we've got new feeds that are going directly into the NDR environment. I haven't got a timetable on it other than to say that I know teams have been working on it for the last few months. There's a whole program of work around moving all data feeds and all data from the old environment into the new. But I'm not sure at the moment. But we can come back at a future meeting to give an update on that as to what the timeline is for all of that work to be completed.
Thanks, Ivan. David, I'll just mention one risk that has been removed. So the cost of transition and ongoing operational support for the development of the app. So that's been removed again from the corporate risk. It's gone to the directorate level. And the draft business case you referenced at the beginning, David, that was discussed and reviewed in the private session of this committee. So to a large extent, that the development of that business case is a mitigation behind that one, hence the drop in risk score. The other one, the NDR phase 3 funding, that has been removed from the corporate risk register. I think, again, just worth noting that related to phase 3 funding, not the longer term funding, which Ivan probably wants to just make sure is highlighted, because it's not long term funding that's been taken off the risk register.
Yes, so that's to do with the longer term sustainable major programs funding. What we were finding was, because of our mechanism of escalating risks, each program was raising pretty much the same thing, and then each of those were coming up and kind of crowding out our risk register. And so we've taken the approach that this is, you might call it like a systemic risk, in that the same risk underlying causes and the same underlying issues are underneath all of those. So it makes more sense to present them in the corporate level as one consolidated risk. And we're managing that through, lots of conversation and communication with Welsh Government to try to mitigate that uncertainty as best we can.
Thanks, Ivan. David, those were the changes
Okay.
in terms of risk. So happy to take any further questions.
Okay, thank you for that summary, Chris. Anybody got any questions on the risk register before we move on? No, okay, I think that was an excellent summary, Chris, so thank you for that, and thanks for the additional information, Ivan. Right, we've got to the part of the agenda where we're going to take a comfort break. I'll take slightly less than the 15 minutes, but if we can all resume at 12:35. And could I remind everybody to turn off your camera and stay on mute during the break, and we'll resume in about 12 minutes at 12:35. Okay, thanks for the moment. Bye. Okay, I think we're ready to resume. So welcome back, everybody, to the second part of today's Programmes Delivery Committee. We're now going to move on to part 4 of the agenda, which is the annual assurance reports. We've got 2 that we're planning to cover this afternoon, Welsh Intensive Care Information System and Welsh Patient Administration System. So I'm going to quickly hand over to Ivan, who's going to take us through the first of those with support from colleagues.
Well, I think the emphasis is on support from colleagues, actually.
This is another quick pass over, is it?
Yeah, I've got wonderful colleagues on this and other programs, as I said this morning. So I am handing over. I'll see if I can get this right. I'm handing over to David, I believe.
Okay, cool. Thanks, Ivan.
That's what I'm expecting. Are we going to have the slides back up if possible, please?
Yeah, I'm sure Laura can help.
Or do you want me to, Laura? I can. Great, thank you. So if we can just move straight on to slide 2, it's probably the best place to start. So the bit of background first about the Welsh Intensive Care Information System. It was born out of Together for Health and a delivery plan for the critically ill, and the NHS Wales Collaborative, as they were then, called for a national system in effect for the intensive care units, the adult intensive care units throughout Wales. Clontarf Morgannwg was the only health board to have an application in situ. Have one, in fact, still, but not across the whole of the health board. But other than those 2, the remainder of the remaining health boards all had no digitisation of their intensive care units. So the approach here was that the delivery plan, the collaborative delivery plan, was going to pay revenue for this programme, and a proposal was put to the Digital Priorities Investment Fund, DPIF, for Welsh Government to fund the capital, with various aims as highlighted there, really, the strategic drivers. A system capable of replacing all paper charts and storing the structured clinical data. So if you have had the misfortune to be in critical care, you'll know that the patients have a variety of electronic devices attached to them, and there are all sorts of observations and readings taken. But typically they are taken, although there are digital signals and it's created digitally, typically they end up as a paper printout and stored in a clinical note that grows very quickly over time to capture all these signals from all these machines. And this project aims to take away a lot of that paper and store that get that good structured clinical data and make it available for the delivery of better patient care in the first instance, but also for other purposes thereafter, be it better provision of the service or for delivery of safer care in the future as well. The contract was awarded to a supplier following a procurement, and we have a solution that is based on premise in our national data centres, and it features integration to many of those bedside devices, but also integration into the national architecture. So there are, for example, demographics come from the electronic master patient index. There's feed from pathology, and there are outputs coming from the system that provide information into the Welsh Care Record Service, for example, so that any clinicians treating the patients who aren't in intensive care have access to summaries of patient treatments, etc., that have been carried out whilst the patient is in intensive care. The status is displayed there in the blue box on the right-hand side. I was just going to highlight that the penultimate bullet that we, with the agreement with the supplier, when the project was being set up, we agreed an agile incremental approach. I think the incremental approach is the most important part here. So module by module, incremental delivery, testing of that, each module one by one. And I think there were 10 increments planned for the development of the whole solution, but using that incremental delivery to try and engage the users throughout the process rather than leaving it all until the end. So if we could move on to the next slide, please. So this is a bit of a timeline of the high-level timescales that we have been working to. So I won't read it all out verbatim, but as you can see, we started this was started pre-COVID, and the contract was awarded in the business case was agreed by the chief executives across Wales, and the contract was awarded in 2020. The configuration workshops started to take place during the COVID pandemic. Clearly, intensive care was a real focus for lots of activity during COVID, and we had to accept that the clinical time was paramount during that time, and we suffered therefore some delays at that point, as you might have expected, due to a lack of availability. As COVID went away and was dealt with, the incremental drops of development that I spoke about earlier started to come through, and we progressed through basically through 2020 with a view that we were going to go live in January 23, and the Grange in and Iron Bevan was the agreed pilot for the implementation. But what we discovered towards the end of that period was that some of the configuration work that had been done back in 21-22, particularly around medicines and around pathology, was deemed to be unacceptable. So there was some rework to be done around pathology and the way that pathology results were integrated into the WICIS solution. But there was also a bigger piece of work then around medicines and drug therapy. In terms of timing, the DMTP came along after WICIS was initiated. So WICIS itself has within scope some medicines functionality, but it's not a full e-prescribing solution that's being bought, and it doesn't include, for example, decision support systems. And we think there was a bit of a shift in terms of people's expectations. So we're going through as NHS Wales, we're looking at e-prescribing solutions, but within intensive care, we weren't looking at a full decision support system. So we didn't go live in January 23 in the Grange in Iron Bevan. That was put back to November 23. The drug therapy module was largely redeveloped through a process of working with clinical colleagues, and we worked towards that November 23 go live. However, in the summer of 23, as the health boards began to see the full solution as opposed to an incrementally delivered solution, there were various concerns were raised about the flow and the usability of the system, together with some specific defects and clinical hazards. So we arrived at the end of last year with an Iron Bevan as the primary, as the pilot site, still in their UAT, round of UAT, and going through their clinical safety log as well. That completed late in January. So we find ourselves in the position where we are A, much delayed, and B, we have a solution that we still need to do some work upon. And as a consequence of that, we took the decision that the DHCW Chief Exec has written out to health boards to asking them to recommit their intentions to implement WICIS, as they had affirmed in 2019. So if we can move on to the next slide, please. We thought it was worth highlighting some of the drivers, the benefits that this solution should deliver. Doesn't come out very well on the slide, but there were 5 principal benefits, which are the highlighted ones on the right-hand side of this diagram, starting at the top with a 2% reduction in drug spend. So the 5 on the right-hand side were the ones that were highlighted as part of the full business case back in 2019-20. But during the process of development, we've collected the 4 on the left-hand side. So reduction in variation, improved information and automation for benchmarking and audit, improved patient safety, and improved quality of care. So those 4 have come through from the configuration and development workshops as the process has gone through. And this in essence is what we are trying to achieve with this project. If we could move on again, thank you. So with this slide, I'm trying to illustrate how we have approached this project. So in the boxes on the left-hand side, it goes through the sorts of resources that we've used to engage with the project. So within health boards, each health board has had basically from the start a clinical lead assigned to the project with a session a week available to work on the project, and we've been reliant upon those individuals to attend all the development work sessions, project boards, etc., to ensure that it's a clinical system that we are delivering. As health boards get closer to their implementation slots, there is further funding has become available. So the 6 months before implementation, a full-time nurse lead is included for the health boards, as is a full-time project manager for the digital teams within the health boards as well. Nationally, we have a full-time principal project manager working on this with a project team beneath her. We've got a couple of project managers and project support staff in there, and they support the health board funded project managers as well with their local implementations. And then below that there is a wider national team. So we've got, as you would expect, there are multiple work streams here. We've got development resources, testing resources, commercial, business change, service management, etc. But we've also had full-time pharmacy resources, particularly when we're working on the drug therapy module, and an application architect as well. And we use this team to get ongoing engagement and liaison across the range of work streams for the health boards. On the right-hand side of the slide there, I spoke earlier in the presentation about the incremental delivery, development delivery that we have used here, and that's come through not just in the development but in the requirements gathering beforehand. So requirements were gathered from health boards, and then there were stakeholder engagement sessions, clinical reference groups, etc., when we were looking at the configuration and development of the system. Development fell into 10 drops, as I explained earlier. In terms of testing, we've had a national testing lead and a tester assigned within DHCW, and they've tested each drop as it's come through. And we have shared that testing then with the health boards. UAT by the health boards has seen subject matter experts, typically the clinical leads that I was talking about earlier, getting involved in the review of the system. But as we got to an RM Bevan, we've had a far wider UAT across the whole of the critical care service. Okay, if we can move on again. Thank you. So this slide sets out the 6 health boards and the configuration of those 6 health boards. We have 3 health boards, an RM Bevan, Swansea and Cardiff, where all their ITU resources are concentrated in single sites. And the remaining 3 health boards, being Betsy Cadwallader, Hywel and Cwm Tafn Morgannwg, have intensive care units, smaller intensive care units split across their district general hospitals. So 2 different sorts of configurations really for the health boards. The next slide is the slide that we saw earlier in the agenda. So this is the assurance report, the monthly, the Q3 assurance report, and it goes through the overall status. And as we said earlier, we're in a position at the moment where an RM Bevan didn't go live in November 23. They have now completed their UAT, and they have completed their clinical safety review as well. We're at the position where we need to assess how long it will take to refine the system in such a way that it's acceptable to Aneurin Bevan and the other health boards. But for that reason, we don't have an agreed implementation plan because we're still doing the assessment of how long it will take to get to work with the system supplier to get the solution ready for the health boards to UAT again. As I mentioned a couple of slides ago, Helen Thomas has written to the chief executives asking for their support, and we continue to work with each of the health boards on their implementation readiness and their UAT feedback. There is a risk identified there around costs. As the programme is extended, as the timelines extend, then the cost of the running the project will increase as well. A, we have to pay for changes, and B, we have a project team that is in post for longer, and that reduces cost pressures as you would expect. So if we could move on to slide 8. So I've started to talk about some of these, haven't I? So the delayed implementation dates bring pressure onto the project in terms of A, the costing, and B, the delay in delivery of benefits. So they start to change that equation. And the longer, the more delays there are, then the availability of resources becomes a more acute problem, because we need people for longer, we need support of the health boards for longer, and we as soon as delays are incurred, then you start to lose some of the focus and the momentum on the project. The third risk there is identified as the move of the data center to. So WICIS, as I said, is hosted within the National Data Center, and we had a potential issue or a risk rather around that migration of kits. But as we have, we don't yet have a go live date, that one is largely mitigated, although not by a way that we would have wanted. So on the right hand side of the slide, I think I've talked about the issues. We need to resolve the UAT and clinical safety feedback, and we need to work closely with the supplier to get that done in a timely fashion. I have spoken about streamlining of the project, and that's a common common feedback now from the health boards. So we've put lots of functionality in there, and as a lesson learned, it's when the users have seen all the functionality together in one place, the workflow within the system and the way that they move around the system makes it clunky, and that incremental delivery, although it's been good in terms of keeping people engaged throughout and giving them something visible and something tangible, the lack of an end-to-end view has proved problematical for us. So if I can move on to the final slide then. So we are working in 3 strands at the moment, largely in parallel, those being the solution, the governance and the implementation. So the solution is, having said we're working in parallel, I think the solution is the one closest to is absolutely on the critical path here. We need to work through the defect log and the UAT list, principally with the supplier, but also with the health boards, to understand the timelines that the supplier needs in order to complete those developments, any costings that are part of that, and to ensure then that we have health boards lined up ready to implement as soon as possible thereafter. In terms of governance, we need to learn, we hope we are learning some of the lessons learned that I highlighted in the previous slide. So the redevelopment work of the drug therapy module, although it was a delay, we believe we've got to a point of a better solution than we were at before, and we'd like to use some of those learnings in the continued development of the solution, particularly around the streamlining that I've described. And then implementation, the funding window for this is until the end of March 2025, and we have yet to implement into any critical care unit. So we are looking at different ways and approaches for implementation, whether things can be done in parallel, etc., and looking at the way that we train. So if we can simplify and streamline the system, then the degree and level of training will be different, and we need to start to take that kind of those kind of things into account when we are agreeing a new implementation plan with the health boards and indeed with the supplier. But going back to the governance there, really, it's key that the changes that get made in this next phase are changes that are agreed on nationally. I think with all of our projects, there's always a danger that whoever is the lead health board, that we run a danger, don't we, that we deliver something that works for one health board and not the remainder. And it's by using those national groups that we will endeavour to avoid that going forwards. Okay, thank you.
Thank you, David. Marion, you have a question?
I do, and thank you, David. That was a very clear summary of where we are. You talked about the chief executive writing out to health board chief executives just to reaffirm their commitment. And the likelihood, I'm sure, is, as they all signed up back in 2019, that they would be keen to progress this. But in terms of the new risks within the NHS landscape, what would be the impact of one health board, if not more? I guess reviewing their commitment and pulling out. What would be the impact on the wider project of that scenario if it were to happen?
I think it goes back to the benefits that we're trying to derive, doesn't it? So you would lose the benefits from that particular health board, but some of the benefits are about not just the benefits to the intensive care unit that the patient is in at the moment. Those patients end up elsewhere. They can move from one health board to another, so they could move down the M4 to Cardiff, for example. And so there are benefits, or there are benefits from a national perspective if the view of the patient is the detailed view of the patient is available throughout. Now there are mitigations to that in that summaries of care are written out periodically and are available elsewhere for clinicians to pick up. But that cross-border stuff, I think, is where we would lose some of the national benefits, particularly in areas that work regionally rather than individually.
Thank you, Dave.
Okay, thanks, Marion. Anybody else got any questions? Otherwise, I've got a couple. Okay, so I'll take a go. So two questions from me, please, David. And again, thanks for the clarity on the presentation. So the first is, we've talked about some work to address some of the issues at Aneurin Bevan and a plan being developed around that. Do we have a target for when we're hoping to go live with Aneurin Bevan?
We haven't got a specific target. No, we've got an immediate deadline of the end of this month. We have a programme board. I'm going to say the 29th of Feb. Michelle will probably correct me if I got that wrong. But we need to have done that made good progress on that assessment by then, because without that assessment and some knowledge about how long things are going to take to rectify it, then it becomes a bit of an academic exercise setting a date, right? You're going to go live by the 1st of February, 1st of March, sorry, 1st of May, whatever, and we lose people. That we are looking at sort of the art of the possible. So if we need to finish by the 31st of March 2025, what would that mean in terms of and trying to do a bit of reverse planning? But until we get to the board at the end of February and we have some better view on that assessment, I think that would be counterproductive.
Yeah, okay, that's a fair point. I think given that we have a compressed timescale and an end date, and we've got a number of rollouts to do, there comes a point at which we just can't do all of those rollouts. So there's probably a date sometime this year when, if we haven't deployed at Naira Bevan, we've compromised the programme as a whole. So it would be good if you could give that some thought, or the team could give that some thought and come back to us on that, just so we know the window within which we're working. And the second point was around the lessons learned, which it's really good that you've captured that. And to put it in context, to have kept the programme going during the COVID pandemic when intensive cares were overrun is a remarkable achievement. So set against that backdrop, I understand why some of the issues are now coming out that we've got, basically. But I think there's important lessons learned there in the approach we've taken, which would inform some of the other programs we've got going forward. So it would be worth, when we've got to the end of this, making sure that you've captured those and shared them a little bit more widely.
Yeah, and that's kind of ongoing stuff. We had a directorate timeout late last year. Can't remember the exact date, but we did try and look at a couple of projects, Wikis being one of them, and look at the lessons learned at that point and how they might be applied to other programs. So we were talking about Digital Maternity Cymru earlier, and some of the lessons from this and other projects have gone into some of the slight change of approach there. Yeah, it's getting that feedback from live programs and projects about what is working and what isn't. I think is really key to making sure that as an organisation we learn and improve. Yeah,
absolutely. Okay, thank you for that, David. We've got any more questions for David before we move on? No, I think we're all good. So David, thanks again for that complex picture that you've painted and made it quite clear for us. Next item on the agenda is the Welsh Patient Administration System, and for this we've been joined by Sam Lloyd, who's our Executive Director of Operations. Welcome, Sam. Over to you.
Thank you, David. I will just share my slide, so bear with me for a second. Okay, hopefully everyone can see those. Yep, okay. So I've gone back to first principles with this, really, which is to set out effectively what is a patient administration, what is the Welsh Patient Administration Service, so that we can set the context of the program that, or the system that this program is impacting, and then set out the background behind the program, and then to set out the progress that we're making in the various work streams that are underway. So the patient administration system is a computerized system which is used in healthcare organizations to manage patient data. It's used to track demographics, medical records and financial information, and it's also used for scheduling appointments, managing beds and managing outpatient and inpatient care episodes. So really critical to the operation of secondary care services in this context. So the Welsh Patient Administration is an instance of that we have built for Wales, and it is used across all of the health boards with the exception of Cardiff and Vale. WPAS is obviously a critical system to the health boards, and it helps to ensure the accuracy and completeness of patient data and helps to streamline clinical workflow and administrative workflow within health boards, and ultimately improves the efficiency of care delivery. And critically, WPAS is integrated with a large number of other healthcare information systems, both nationally that DHCW operates, which includes RADIS, WLIMS, WCP, the Welsh Clinical Portal, and across a range of local systems which are operated by the health boards. And the integration of these systems is what allows for the sharing of data within and across health board boundaries. So it's really a core part of the national architecture. So why are we doing this work, and what does it mean? So on the 1st of April 2019, Welsh Government transferred responsibility for health services in the Bridgend area from one health board to another, and as part of that process the health boards were renamed to be what is now Swansea Bay and Cwmtaf Morgannwg University Health Boards. SLA arrangements are currently in place between those health boards to permit Cwmtaf to use the Swansea Bay ICT services to manage patients who are treated out of Bridgend whilst this work is underway. And that's really it's an interim position to allow the safe transition of services. And the main system that really enables that work is WPAS, because a large number of, all of the Bridgend patients, their data needs to be moved from the Swansea Bay instance of WPAS to the Cwmtaf Morgannwg instance of WPAS. So this is really a project which is being run out of the Cwmtaf Morgannwg Health Board. DHCW is a major contributor, but we are not the owner of this activity. DHCW has received Digital Priorities Investment Fund monies for a range of activities which relate to this, including some overall PAS improvement activities, some work for Velindre, some work for Betsy Cadwaladr, plus this particular. This is part of a range of activity which is funded through DPIF, but is a core part of that. As I've alluded to, multiple systems are impacted by this boundary change, including both national and local. There are temporary service level agreements in place to allow the continued use of the Swansea Bay instance of WPAS by CTM. And crucially for this project, there are over 500,000 patient records that exist in the Swansea Bay instance of WPAS which need to be moved. So it is a very significant data migration undertaking. Only CTM records need to be transferred. If there is genuine Swansea Bay activity on the patient PAS record, then those activities will remain within the Swansea Bay PAS. So that complicates matters further. There isn't necessarily a clear-cut boundary or immediately obvious boundary around which data needs to be moved. And the transfer of records between PAS systems will change the patient identifying references, with only the NHS number remaining constant. And so there's a lot of data manipulation that needs to be done through this process as well. Project timelines, that's very small on the screen. I won't read through it all, but effectively there are two work streams underway here. So one is that migration of data from one PAS instance to another, and the second is the further work to determine the impacts on other downstream integrated systems. So the data migration is now well underway. There are a number of migration tranches which are currently being planned. We're in the midst of tranche 3 at the moment. There will be a series of testing activities that will take place post data migration. Our current projected end point for that migration activity is May 2025. That does pose a risk, which I will come to in the risks section. The work on the understanding the impact on downstream national services is currently underway. So we're in a bit of a discovery phase with that at the moment, which is determining which systems are in scope, and then to understand the impact on those systems, to therefore work out the cost and impact of work that needs to be done, and then to build that into the plan. So this one is at a bit excuse me, at a bit of an earlier stage in the planning cycle, but we do expect by the middle of February to have a clear idea on what that downstream impact is, and then to start to be able to plan to build that into the deployment. And then finally, risks and opportunities. As I've alluded, the DPIF activity covers the PAS work, but so the work that needs specifically to be done on the WPAS service, but it doesn't currently cover the other work that needs to be done on downstream integrated systems. So once we've got that impact assessment, we'll then be able to understand what that means in practice from a financial perspective. There is a requirement to build a test environment so that we can QA the data transfer between the PAS systems. Given the complexity of the work, this is really important. We've got a plan in place now for how we intend to deliver that, and it will be a cloud native service which will help to keep the costs manageable. It's also important to note that both Swansea Bay and Clontarf Morgannwg are part of the RISP and LIMS 2 programmes, which run concurrently with this boundary change transition work. So the change load across those health boards is significant for the duration of this programme, and we're working with them closely to help manage that. Again, as I've mentioned, the funding that we have to enable this work is only available currently until the end of March 2025, whereas our projected programme timelines are May 2025. We are looking to see what we can do to bring those timescales to within the funded period, but there are additional complexities because we need to take a whole financial year's worth of data. So by moving the dates forward, we potentially significantly increase the amount of work that needs to be done from a data migration perspective. And then lastly, we are looking at, this is more of an opportunity than a risk, we are looking at the the technical architecture, for WPAS. We've just undertaken an external architecture review, which is helping us to understand what a roadmap for moving WPAS to a much more cloud native architecture will be. It's also important to note that this is a program that predates DHCW, so the approach that was taken was agreed before the organisation existed. So we're in the process of kind of going back through our own decision-making processes and ensuring that we're comfortable that the approach that we're taking is the correct one, given how far the system has changed in the intervening period. And there are potentially opportunities to look at WPAS standardization and centralization as a potential outcome here, but this, it's early days for those conversations, but we are starting to look at that in earnest. And it also has a bearing on the wider conversations that are starting to happen nationally around considerations for moving to an EHR platform, and what does that mean for DHCW's national services. We think that WPAS plus the Welsh Clinical Portal and plus the Welsh Nursing Care Record are the three systems that most closely approximate PAS EHR functionality. So we're about to kick off a piece of work that will look at the economic case for continuing to develop those three systems over the next 5 years, and compare that with purchasing commercial, either monolithic or modular EHR products, but then also looking at the functionality gap as well. So there might be areas where our products are more mature or areas where commercial products are more mature, so we can start to get a much more rounded picture, which will inform national architecture considerations over time. Thank you. So happy to take any questions.
Thanks, Sam. Really useful presentation, really clear. Can I just ask committee members if you've got any questions on what Sam has outlined in terms of PAS? No, we don't seem to have any. So I've got a couple I was going to ask Sam, if that's okay. So the first one relates to one of the bullet points you've got on there, which is both Swansea Bay and Clontarf Morgannwg are both having to implement RISP and LIMS in addition to this work. Does the date that you've got currently, May 25, take account of the fact that there's some overlap in the programmes within these health boards?
It mainly takes into account the complexity of the work that needs to be done and the funding envelope, but we are working with the two affected health boards to try and align on RISP and LIMS. I think so. These timelines are not directly being formed around the RISP and LIMS timelines, but we are trying to take them into account and manage the overall load.
Yeah, it was the load aspect I was concerned about, because the health boards will have some limitations on the resources that they can use to deploy both RISP and LIMS, and this programme also just adds to that workload. So presumably we're having those conversations with the health boards, and
we are.
That's reflected. Okay.
Yeah.
And the second question I had was around the funding available and the fact that the programme goes a little bit beyond that. And then if we bring the end date to try and match the funding envelope, we increase the complexity, which is never a good thing to be doing. So are there any other options under consideration in terms of just seeking some more funding so that we don't have to compromise the complexity of the programme any further than it is at the moment?
Yes. So the additional DPIF ask, assuming there is one, will be factored into the conversations that we'll need to have with Welsh Government about that. So yeah, we're picking that up with Claire.
Okay. Thanks, Sam. Ruth, you've got a question.
Thanks, David. Thanks, Sam, for that update. I mean, I know this has been an ongoing issue for quite some time. Just like a little bit more on the technical architecture review of WPAS, because clearly we're carrying out quite a big piece of work to rectify something which arguably, you know, I'm not quite sure why it happened in the first place, but what are we putting in place to make sure that we don't end up in this situation again if there are other boundary changes, other system changes? You know, I mean, I think it doesn't feel like a national system if we have to go through big data transfer exercises every time something changes.
Yeah, that's absolutely right, Ruth. And the major reason we're having to do this is because there are multiple instances of WPAS which exist across the landscape. So, you know, we physically need to move data between instances when boundary changes like this happen, and we've had to do others in the past as well. So this is not the first of these exercises that we've had to do. It's all bound up in a lot of ways of working complexity. You know, there are different ways of working which different health boards have implemented across their different PAS instances, which make consolidation very difficult. But, you know, very difficult isn't the same as impossible, and we're really keen to try and pursue how we can move this conversation into a different space. And one of the options, I think, is to try and build a compelling or, you know, get WPAS nationally into a compelling place where we can then, you know, why wouldn't the health boards want to come and join us? You know, that's the position we want to get to. So that's the purpose of the architecture review, really, is to think how can we modernize this platform and get it to a position where it can be cloud native, resilient, performant, etc. You know, and make it a compelling offer. But we're still going to run into the complexities around local ways of working, which is going to be the really difficult part to overcome, I think.
Thank you. Because I mean, I think, you know, it's just worth remembering from the perspective of a patient. I think all this happens anyway, right? I think if I go to hospital anywhere in Wales, everybody has got all of my information, and I shouldn't have to worry that people need to transfer stuff around behind the scenes. That makes things difficult for the clinicians. It makes things difficult for, you know, patient care. So, you know, I mean, I think for us moving forwards, this is the key thing we need to be focusing on, isn't it? When we think about how you work across the whole of the system and get us into a place which means that this sort of thing shouldn't be able to happen again.
Yeah, completely agree.
Evan, you've got a question or a comment?
Yeah, more a comment, I guess. So I'm cautiously optimistic that it wouldn't happen if we were doing it now. So PAS goes back a long way, and Myrddin, the predecessor of PAS, goes back even further. And they predate even our structured approach to data standards, which is 15 years old or so, with data standards change notices, and they predate by decades the emergence of FHIR and OpenEHR and interoperability and other things. So all those things are familiar to committee members, I'm sure, because we're signaling really strongly in our strategy, in our IMTP, and in a bunch of other things that that's where we are, that's where we're headed, and that's where we want to go. So there's a lot of work to do to disentangle the sort of the technical debt and the legacy infrastructure and the legacy architecture that we have got. You know, I think it's just something that we have to, you know, that we have to work through. The one thing I guess I wouldn't want to lose sight of is that over the last 20 years or so, PAS has served us really well. It's served the NHS really well. It's been a reliable system, and it's delivered a really, really high return on value. and it was great for the purpose that it was originally designed for and built for. But we've moved on, and now we have to look at not what we need in 2023 or 2025, but what we need in 2030 and what we need in 2035, and then what we build now, we'll need something different in 2040 and 2050. So there's a cycle, isn't there? And but we understand, I think, well, and we've done a lot of work to understand the depth of the technical debt that we have, and we've got a clear route through to the future. And we're trying to set that out in our strategy, which board members looked at a couple of weeks ago, and hope that health boards will engage on that and support that approach. And they are strongly bought into the NDL programme, to the standards-based approach, to interoperability, to open architecture. So I'm cautiously optimistic, but I'm always glass half full, as you know.
Okay, thanks for that comment, Evan. Anybody got any more questions for Sam before we wrap up this part of the agenda? Great. Okay, thanks again, Sam, for a really detailed view of what's going on, some of the risks and the opportunities around moving PAS forward, as Evan has highlighted. I'll now move on to section 5, or part 5 of the agenda, closing matters. First item is AOB. I've not been notified of anything in advance of the meeting, so can I just ask participants if there's anything they wanted to raise under AOB? Nope. Okay, great. Next item is the Chair's highlight report. I've noted a few things that I will include. One around the concern around the escalation on cancer. If it doesn't get resolved in terms of additional funding from Welsh Government, we have a significant challenge in front of us, which the organisation is already aware of, but I will raise that as one of the highlights. I'll pull out a couple of things from each of the annual assurance reports that we've received around WCIS and PAS, and some general observations around the fact that funding, which we know about in terms of a strategic issue for us in terms of a more sustainable funding stream, which take away some of the issues that we're facing, and a few concerns around resources, which we know is an ongoing issue in terms of attracting people with the right skills into the organisation while we pursue our strategy of growing our own, which is developing staff that are in the organisation to fill some of those roles. Has anybody got anything they wish to add to the list that I've just gone through? No, great. If you do think of anything, please just ping me an email after the meeting, in which case I'll draw the meeting to a close. I'd like to thank all the presenters and the members of the committee for participation. It's been a rather long session when we take into account we had a prior meeting to this as well. So thanks again for your time. Look forward to seeing you all on the 14th of May when we'll have the next of these committee meetings. Thanks again. Take care.